Okay, you reviewed a study and decided it wasn't a flaming pile of crap. So now what do we do with it? Well, let's apply some of what we've learned over the last few lectures. First, I'm going to talk about an example of a study that I completely made up. This is not in any way a real study, but let's say we have 50 subjects who status post ACLR were tracked for 3 years. We find that after tracking them for 3 years, that those who could perform 17 single leg squats in a row at 16 months out from surgery were significantly less likely to have a second ACL injury by the 3-year mark. So think about what this is saying. What I did is at 6 months, I put people through a battery of tests. I then tracked them for 3 years. I found when I look back, those who sustained a second injury, it correlated with the inability to perform 17 single leg squats at 6 months out. This is actually a fairly common type of study that we see in the literature. Again, I made these numbers up. This is not a real study. But think about the conclusions that people would draw from a study like this, and then they would apply those conclusions into practice. How many people would come up with a conclusion that looked like this? If I can make it so my patient can perform 17 single leg squats by 6 months, I will dramatically reduce their risk of second ACL injury. The application of such a conclusion would be for the clinician to have somebody practice single leg squatting during the first 6 months after ACL reconstruction so they can get them up over the 17 threshold, and that by doing that, they're going to reduce the patient's risk of injury for a second injury. But is that what the study actually says? Can we actually conclude such a thing from this kind of study? No, not quite. We'll come back to this idea in a minute, but first, let's look at a couple other conclusions that we might be able to draw. Another conclusion could be, if my patient can perform 17 single leg squats by 6 months, they would have a reduced risk of second ACL injury. This may sound similar, but the wording is actually a little bit different. In this interpretation, I'm not trying to make them be able to do 17 single leg squats. All I'm trying to do is having my ACL reconstruction patients perform single leg squats to fatigue at 6 months out and seeing how many that they get. 17 or more, and I can say that they're going to have a reduced risk of second injury compared to the people who get 16 or less. This is not an intervention as much as just using it as a predictor. This is better, but I will say that this is actually not what you conclude from a study like I just described. This would be a conclusion you could use. In this cohort, there was a retrospective correlation between being able to perform 17 single leg squats by 6 months and the incidence of second ACL injury. Being that this study is retrospective in nature, all I can do is generate hypotheses from the study. I can't actually draw much of a conclusion from a study like this because it's retrospective. We talked about this before with my random number generator, how once you have a series of numbers generated, or data from it, if you try to look back and create your hypothesis from that, you have a very high risk of picking out just random noise and calling it real. So instead, what you can do is look back at those data and say, I found a correlation. I can build a hypothesis around this. It's possible that somebody's ability to perform a certain number of single leg squats is testing something that actually is a factor in second injury. But the problem here is that a retrospective study like this can only generate a hypothesis, not prove anything. This study is not itself actually a test of that hypothesis. Remember, we talked about this before. You can't test a hypothesis with the same data used to generate it, meaning that you would have to do another type of study as a follow-up to this one before any real conclusions can be drawn. Now, what would that second study look like? Well, we have to do some sort of a prospective study trying to establish the efficacy of this as a prediction tool. This means that you would need to get another 50 subjects, creating a very similar cohort. When you're dealing with only 50 subjects, you need to keep it homogeneous enough that you can draw conclusions from the sample. You don't want 50 vastly different people as part of your group. Let me be clear here. I'm not saying that you need 50 subjects to test this. Honestly, I have no idea how many subjects you would need. It depends on the effect size that you're predicting. Remember Paul Meehl and his strong hypotheses I talked about in another lecture? Maybe you need 50, maybe you only need 25, maybe you need 100. I don't know. My point here is that the original retrospective study used 50, so to keep things simple, I'm just keeping everything the same, but making it prospective instead of retrospective, as I point out right here. Ideally, you're going to try to match exactly the previous cohort that you did in your retrospective study, and now look prospectively at them. So now you're going to run your single leg squat test again at 6 months. Make the prediction that 17 is going to be your cutoff to identify those who will have a second ACL injury. We talked about this in a previous lecture. Being a little bolder in your prediction. You have to have a strong hypothesis to give you stronger reliability in your conclusions. So here you're not predicting that it's going to be over 5 or over 10, or let's just see what we get. You're predicting specifically that it's going to fall at 17. Then you need to see if it actually happens the second time. Now I'll tell you right now, the likelihood of that happening a second time, it's not huge. A test like single leg squatting just has too much inherent variability for it to be very precise in its predictive ability. Functional tests tend to lack precision for this reason. Honestly, this is a flaw in the original design. But for the sake of this lecture, let's assume that this prospective look at this test as a predictive tool was 17 again. Perfect match. So now that number 17 has come up twice. Now we're starting to have a little more strength to the argument. Okay, so now can we say, if my patient can perform 17 single leg squats by 6 months, they would have a reduced risk of second ACL injury? I will say that you have a little more plausibility about this statement, but actually you can't say this from that one prospective study that we just described. What we can say is that in this narrow population of subjects tested, the ability to perform 17 single leg squats by 6 months predicted a lower incidence of second ACL injury. Again, we're very narrow in our statement here. This was a small trial of 50 homogeneous subjects predicting forward in that sample. It may apply to your particular patient, assuming that they fit very well with this exact cohort, keeping in mind that this cohort may be patients that are involved in a research setting or a hospital system that has a very specific rehab protocol that you may or may not follow. Maybe they're looking at only one particular type of athlete, or just one particular gender. Unless your patient ticks all of those boxes, it's actually hard for you to make this kind of conclusion from a study like this about the patient who is standing in front of you. That's because this study was looking at the efficacy of this as a prediction tool in a perfect situation. Given a perfectly controlled situation, can this tool work? The answer from that study was yes, in a perfect situation, it can. That would be efficacy. But perfect situations are not what we're presented with in the clinic. What we are missing at this point is effectiveness. With effectiveness, we're talking about the messy real world. How broadly can we apply this information? We again have to do a prospective study, but this time we need to get another, like 10,000 subjects, and then run the same single leg squat test. I'm just throwing a number out, but it needs to be a huge number. We need random clumps of varying populations across multiple regions. Typically, these are conducted across multiple centers, all collecting data at the same time, looking at this type of thing, all running the same tests. The idea here is that you're going to have broad variability of rehab protocols, broad variability in the demographics. With 10,000 subjects, it allows all that variability. You're casting it out into the real world and seeing how this test works as a predictive tool, or a prediction tool. Again, you're going to make that bold prediction of 17 being the cutoff in this very large cohort of 10,000 varying subjects, a very heterogeneous example. This is how you test things, these kinds of things for broad application, so that the average clinician can apply it to their average patient. Again, this is what we call effectiveness. Honestly, before I would take the time to create a study of this magnitude, I probably would have done more efficacy studies with other cohorts, not to mention replication of these prospective efficacy studies. Having the consensus of them being successful before I did the massive effectiveness study. But I'm trying to speed this story along. Again, with this prospective effectiveness study of 10,000 subjects, you have to ask yourself, how likely are you going to hit 17 again? It's possible, but you can see that we're really banging away at this hypothesis. You can also see how close we are to true broad real-world application, but how far we are from that original study that I described. The likelihood that 17 is in any way accurate based off of that original study is kind of absurd. Again, for the sake of this lecture, let's assume that yes, the predictive cutoff of 17 was supported by the effectiveness study. Now I can say with good confidence that if my patient can perform 17 single leg squats by 6 months, they would have a reduced risk of second ACL injury. I can use this more as a return to play type test. But you can see how much work that it takes and how many hurdles it has to get over before you can draw a conclusion like this. Even then, I'd love to see this effectiveness study replicated. However, probably not very likely to happen. As a matter of fact, just getting this far is not very likely at all. We almost never see this process in our literature. At least, as we have it in this example, we can now make a statement like that and use 17 single leg squats at 6 months as a predictive tool. But that's not the conclusion that I opened up this lecture with. That is not the conclusion that many people would have drawn from that very first study. This is the kind of conclusion people seem to jump to in that first study. If I can make it so my patient can perform 17 single leg squats by 6 months, I will dramatically reduce their risk of second ACL injury. This is not talking about a simple predictive tool. Now I'm talking about an intervention. I'm saying that I'm going to do something in the first 6 months to make it that they'll be able to perform 17 squats in a row. And by doing that, I'm going to take them from one group, people who had a high risk of second ACL injury, to another group, people who have a low risk of second ACL injury. We already established that that is not supported by the original study. But this is also not supported by the involved prospective studies that I described to establish it as a prediction tool. We are now talking about an intervention. So let's clarify the difference between the two here. The predictive tool is a test that is trying to categorize subjects into two groups. Those who will have a second ACL injury, or those who are at high risk of second ACL injury, and those who are not. An intervention, on the other hand, is trying to move subjects from one group, people at a high risk of second ACL injury, into another, people who aren't at a high risk of second ACL injury. Predictive tools and interventions are not evaluated in the same way. What we need in order to test an intervention is a randomized controlled trial. So I want to randomize them into two groups. One group is going to get regular care at my facility, and the other group is going to have regular care with the focus on working to get to 17 single leg squats by 6 months. The hypothesis is that by getting them to be able to do 17 single leg squats by 6 months, I'm going to reduce the incidence of second injury. Now this gets kind of tricky. The problem that we have is what we're actually trying to determine is, with people who otherwise would not have been able to do 17 squats by 6 months, if I force them to be able to do 17 squats by 6 months through practice, will I actually reduce their incidence of second ACL injury? Do I actually cause them to change groups? Now, how do you know they weren't going to get 17 single leg squats before you intervened? It's really hard to identify those people, but let's say I had a crystal ball seeing into the future and was able to establish who wouldn't be able to get 17 single leg squats without the intervention. Do you think that this statement would actually be true? If I make it so my patient can perform 17 single leg squats by 6 months, I will dramatically reduce their risk of second ACL injury. What we often find in these types of situations where we force subjects to get better at what we are testing is that we don't actually reduce their risk of second ACL injury. We just make them good at passing a test. And now that test is not predictive of anything. Remember Goodhart's law? When a measure becomes a target, it ceases to be a good measure. I told you in a previous lecture that this will come up again. We have seen this with hop testing and ACL reconstruction. If you take someone who has not practiced hops and you conduct a hop test at 6 months out, it has some injury prediction validity. But if you teach them how to pass your test without solving the underlying problem, you have just broken your test. So in this single leg squat example, we give them practice to figure out how to get better at performing a single leg squat and give them enough strength endurance specific to that movement in order to complete 17 repetitions. But is that actually their root problem? We will talk a lot more about this in a later lecture. Now again, you saw the steps that it took to get to some more solid and applicable conclusions. But oftentimes, this is all that we have. One study that shows something like our original study. So what would we do as far as intervention when this is all we have from the research? Oftentimes this is all we got. How would we apply what we have in the literature if this is all that is published that is relevant to what we do. The way that I would look at something like this is I would ask, what is it about performing 17 single leg squats that would make somebody be a lower risk for second ACL injury? So I'm asking myself, what all does it take for somebody to be able to do 17 single leg squats by 6 months without practicing it? Well, they would have to have a certain amount of quadricep strength. They would have to have a certain amount of hamstring strength, a certain amount of glute strength. They would have to have a certain amount of balance, a certain amount of squatting skill, a certain amount of things I don't even know what they would be. But what I would try to work on is those things individually separate from single leg squatting. I would make sure that those components are there individually, not just the ability to do single leg squatting. Because if all I have is that one study that I just made up here, which, as you saw, I can't really draw a lot from other than there's maybe something about single leg squatting that's probably not just single leg squatting, that is a factor for second ACL injury. Yes, this stuff is very complicated, but you can't draw simple conclusions from simple studies. As you can see, the way research gives us information is much more complicated than it seems. Each study gives a slight sliver of additional insight. It is a layered approach of very small steps that is well planned out and replicated. Unfortunately, this is rarely what we are given. What we are usually given are several studies all doing a poor job trying to answer really large questions without any real progress. I will leave you with a quote from Isaac Newton. To explain all things in nature is too difficult a task for any one person or even for any one age. It is much better to do a little with certainty and leave the rest for others that come after, than to explain all things by conjecture without making sure of anything.